Now on to the lecture about your bread and butter, soap notes, and common scribe mistakes. So a few questions to start, just to keep in mind while we go through this. What is a soap note and what does that acronym SOAP stand for? Give me an example or think of an example of the kind of information each section holds. What is medical decision making? So we kind of spoke about this in the previous lecture. What is so important about this particular area of the chart? What are some of the common medical scribe mistakes listed in your book, and which do you think you might struggle with the most? So on this slide, if you're in the PowerPoint version, you can actually double click on it. It's in your Canvas weekly lineup, this video where you can click on it. It'll take you right to the YouTube video, but this is a really good breakdown of a soap note. So the S stands for subjective. So this is information provided by the patient. Generally, this will start with a chief complaint. So recall we talked about chief complaint in the previous lecture as why the patient is there. For example, my chest hurts, I'm having throat pain, etc. Using direct quotations for the chief complaint is great practice. This way, the chart knows, everyone knows this is exactly what the patient said. Other things that will follow subjective include history of present illness, review of systems, additional history to include past medical history, surgical history, social history, family history, allergies, current medications, immunizations, and for women, last menstrual period. HPI. So this is something that we've heard quite a few times throughout the lectures, again, under subjective, because this is stuff that's coming from the patient, information coming from the patient's mouth to us. So it includes the description of the patient's pain or symptoms. Remember OPQRSTA, time of onset, palliative or provocative factors, quality of pain, region or location of pain, severity of pain, timing, and associated symptoms. I think in the previous lecture I put alleviating symptoms, and that was incorrect. So palliative or provocative factors are going to be, what makes it feel better, what makes it feel worse, and then A is associated symptoms. Here we see an HPI written in a narrative format. If it works better for your workflow to list out the elements O, P, Q, R, S, T, A, and then put it into narrative format, that's perfectly fine. So a 17-year-old male presents with sharp, severe left ankle pain after twisting his ankle 1 hour ago. He also complains of numbness in his foot. The pain worsens with walking or weight bearing. So we can see we've identified a lot of these elements here. We have sharp, severe left ankle. So quality, severity, region. After twisting his ankle 1 hour ago, so this is the onset. He also complains of numbness in the foot, so an associated symptom, which worsens with walking or weight bearing. So that is a provocative factor. There's also another commonly used acronym, POLDCARTS, POLDCARTS, where the P stands for previous history. So HPI, history, present illness, or previous history. O is onset, L is location, D is duration, C is characteristics, A was aggravates, R is relieves, T is time, and S is scale. So that common question on a scale of 1 to 10, how bad is your pain, with 10 being the worst pain you've ever experienced? Review of systems. So this is something you've heard a couple times too since starting the class. So there are 14 systems that we have the patient review, or we review with the patient, rather the provider or clinician reviews with the patient when they're being admitted, when they're coming to the doctor, etc. So there's constitutional, eyes, ears, nose, throat, cardiovascular, respiratory, gastrointestinal, genitourinary, musculoskeletal, neurological, integumentary, psychiatric, hematological, endocrine, and immunologic. And on this slide, you can see some of the things that will fall under each of those categories. Weight gain, weight loss, fever, malaise, chills, fatigue. So these are our constitutional symptoms. Cardiovascular, sweating, swelling, palpitations, respiratory, shortness of breath, cough, wheezing. So there are some definitely that if you're on the clinical side, you want to make sure that we're always reaffirming with patients if they're having them. Obviously, we want to know if they're having shortness of breath, chest pain, etc. Your role as the scribe is just to notate who is this filled out by, who is this reviewed by. Filled out by patient, reviewed by physician. Physician reviewed reviews, or physician asked patient review of system questions, grossly negative. You know, it's your job just to make sure that all of this is documented. Moving on to objective. So objective findings, they're unbiased and include things like the physical examination, vital signs, measurements, diagnostic test results, and any procedures. So the way that I would remember objective information is that it's something that somebody could come in behind me and replicate. Or somebody could come behind me and look at the same data and see the same information. You know, what a patient says might change from day to day or moment to moment, but you know, diagnostic test results from this date and time are always going to be the same. If you aren't sure if something is objective, ask your physician, but also keep in mind that there are things that have nothing to do with the opinion of the patient or provider. They are measurable and often reproducible, like vital signs, height and weight, etc. So the PE or physical exam, again, under objective. So this is often referred to as the head-to-toe examination. Findings are organized by body system, as you can see here on the right, the major body systems that you would be listening for in a comprehensive, so overall thorough examination. The systems in bold are recognized by the CMS for physical exam, and there are 12 of those. Findings are organized by body system. In some instances, you might have a template. In most instances, I'm going to tell you, in an EHR, you're going to have a template where you're clicking. There's not as much free text, so it should go quickly once you're accustomed to that EHR system. Depending on the physician, they may choose to call out the information to you in real time or wait to tell you when you're outside of the room. So again, that's something you'll learn in practice when you're working with your physician. If the physician does not assess a certain body system, do not document on it, remove it entirely, or mark/notate not assessed. Depending on the patient and situation, unable to assess may be an appropriate documentation. So a situation where you're unable to assess the bilateral radial pulses would be if the person had bilateral upper extremity amputations. You can't assess a radial pulse. Again, so in some carriers, unless you're seeing new patients, you're not going to see a full documentation or a comprehensive physical exam. In most places, you're going to see a focused exam because the doctor's there to look at, you know, 3 to 5 systems, not at 12. So again, that's something you'll learn based on the care area you end up working in. So here's just an example of a normal comprehensive exam. I have in bold a lot of common acronyms, but I will say them fully here. So constitutional, no acute distress, appears well developed and well nourished. Head, ears, eyes, nose, throat. Head is normocephalic, atraumatic, conjunctiva clear, pupils equal, round, reactive to light and accommodation. Extraocular movements intact, tympanic membranes clear bilaterally, mucous membranes moist, cardiovascular, regular rate and rhythm, no murmurs, gallops, rubs, capillary free flow, less than 3 seconds, no edema, radial pulses 2+ bilateral, pedal pulses 2+ bilaterally. Respiratory, lungs clear to auscultation bilaterally, no respiratory distress, breath sounds equal. Gastrointestinal, abdomen is soft, non-tender, non-distended, bowel sounds ×4 quadrants. Musculoskeletal, grossly intact, no swelling or deformities. Chest wall, chest pain not reproducible by palpation of chest wall. So this would definitely be like if the patient's even complaining of chest pain. Skin, clean, dry, and intact, warm in color, normal for ethnicity. Neurological, cranial nerves 2 through 12, grossly intact, no focal neurological deficits. Alert and orient ×4. Psychiatric, cooperative, appropriate mood and affect, hematological, lymphatic, immunology, no lymphadenopathy. So you can see there's a lot of ways that charting will be shortened even if you did have to free text. Like I said, in most cases, you're going to be able to click and be like within normal limits or put exactly what the findings are. Also under the O and SOAP, vital signs, things like heart rate, blood pressure, pulse ox, temperature, pain rating. So this may be obtained from the nurse's notes or from observation in the exam room. If the patient is on a cardiac monitor, you should note this as well with the appropriate cardiac rhythm. And if you don't know the rhythm, ask. Your text goes into what is considered normal versus abnormal when it comes to vital signs. However, it's not necessarily for the medical scribe to determine. It is very important that you record accurate and timely vital signs. Oftentimes, bedside monitors are connected to the computer system, and much of that data can just be quote-unquote dropped in. This will, of course, depend on your patient care area. So also under objective diagnostic studies, things like labs, urinalysis, EKG, radiology. We've already learned that part of the role of the scribe is to keep track of these studies as they're ordered and let the physician know when they're resulted or completed. We also have learned that it is part of your job to help facilitate timely results. Some examples, again with some acronyms: EKG normal sinus rhythm at 76 beats per minute, no ST segment changes, no T wave abnormalities, unchanged prior to last EKG on whatever date that was. Chest x-ray, no acute disease, labs, cardiac enzymes, basic metabolic panel, complete blood count, all within normal limits. Medical decision making, again, something we've talked about. So physician decision making is explained in this section. This is an area to document any necessary CMS core measures and admission criteria. Will be structured differently depending on your physician. Generally, it will contain differential diagnoses based on the history and physical. So differential diagnoses are different possible causes for the patient's presentation, the test performed and the results, the working diagnosis, and any treatment rendered, and the plan of care. How you gather the information to document this will depend on your level of experience as a scribe and with your physician, as well as the complexity of the patient. Again, differential diagnosis. Any explanation that the physician determines for the patient's presentation. It will either be dictated to you as its own separate section or be included in the medical decision making. Will depend on physician preference. So the A and P of a SOAP note: assessment and plan. Diagnosis, disposition or plan of care, calls, consults, reevaluation. So diagnosis, always document a diagnosis in the chart. And you will learn, especially if part of your job is associating ICD-10s and CPTs, that the chart will only let you go so far if you have not put in the proper ICD-10 diagnosis code. This is important for billing purposes and admission criteria. Never leave it blank. Disposition just means, what is the plan for the patient? Are we going to discharge? Are we going to transfer? Are we going to admit? This is also where discharge and follow-up instructions should be imported for the patient being discharged. Calls and consults. Any calls to other providers, specialists, ancillary and interdisciplinary services should be documented here with who, what, when, etc. Who did the doctor call? Who did they consult? Who did they speak with? Reevaluation. Anytime the physician has contact with the patient, record the time and changes in the patient condition and treatment, and the time spent. Remember, time sometimes will become a factor when it comes to reimbursement. Other charting elements that you might be in charge of include procedure notes. So this video also is on your Canvas weekly lineup to watch. It's just an example of a timeout. So timeout, consent, the indication for the procedure, what preparation was done, what medications were used, what technique, what time, the outcome, and performed by. Sometimes it'll even ask you to put down the names of other people in the room. So these are some common procedures mostly performed, I would say, in a higher acuity area or the emergency department, so somewhere like an ICU or the ED. So an IND, an incision and drainage, conscious sedation, fracture, dislocation reduction, laceration repair, endotracheal intubation, central line placement, and lumbar puncture. Many, if not all of these procedures will require their own documented timeout, and generally there will be a place in the EHR for this. Critical care notes. So we talked about critical care time already. So high acuity complex cases where the physician spends more time than he or she would typically can bill for critical care time based on services rendered and time spent. The first increment of critical care time is 30 to 74 minutes. Each additional 30 minutes is billed in increments. When documenting critical care, be sure to document all documents reviewed, all tests ordered and their interpretations, all consults, and any other element of care. This is not just for critical care, this is for all documentation, but it becomes especially important for critical care reimbursement. Critical care notes receive higher reimbursement, which puts them under higher scrutiny. Some of this will be a review from the last lecture, but components that must be met in order to bill for critical care time. So evidence of critical illness in which one or more vital organ systems is in danger of deterioration, which is life-threatening to the patient. Physician directly involved in interventions, at least 30 minutes involved in patient's care, including direct bedside care, documentation time. In this case of the scribe, time spent discussing the case will count towards this. Discussion with other medical staff, time spent reviewing labs, radiology, and old records, and time spent discussing the case with family members, caretakers, if the patient is unable to communicate. Time is considered an approximation. Remember, we talked about how we're not starting a timer. It is approximation. Important to include frequent reevaluations. Every time the provider has to go in and do some kind of reassessment, you need to record the time. If any adjustments to care were made, etc. The following procedures can be billed separately for critical care time. This would be endotracheal intubation and central line placement. Now let's review some common medical scribe mistakes or missteps. Not keeping an active patient list. So every medical scribe should keep a patient list in order to keep the physician on task. List can include room number, patient last name, HPI, review systems, medical decision making, and disposition. As the patients reach each step of the care process, you can check it off to keep yourself on track as well. If you have a document with a patient's PHI on it, be sure to remember HIPAA and treat it appropriately, aka don't leave it out and about on your workstation if you are not present. Not signing out at the end of your shift. So make it a point to sign in and out of your physician before and after each shift. In many EHRs, you will continue to work under the same physician's name if you do not hard sign out or log off. In other words, don't just X out of a program. So that means if you go into work on Monday and you're working under Dr. J and you don't do this hard log off, then you go on the next day and you're working under Dr. M, it's going to look like you're still documenting patients under Dr. J, and that is a problem. If you need to, make yourself an end of shift checklist that includes logging off of the EHR. Using the patient interview instead of the chart review for recent hospitalizations, test results, etc. So patient interviews are great and valid for subjective information, but that's from the patient's perspective. So information that goes into the objective area of your note is used for comparison, as in previous visits to the emergency room, previous visits to the hospital, and the results of labs and studies ordered during that time. It's important that you just use the chart itself. When possible, you should retrieve previous and pertinent records for accurate data versus what the patient remembers or recalls. Missing pertinent negatives from the HPI. So pertinent negatives can be just as important as relevant findings. So if the physician asks questions and the patient answers, it is essential you document these answers even when the answer indicates a negative or a no response, especially when it comes to things like shortness of breath, chest pain, that kind of thing. We need to know no shortness of breath, no chest pain, no dyspnea on exertion, no nausea, no vomiting, no headaches, no dizziness. So an example here, are you experiencing shortness of breath? If you were to leave this blank, it looks like the provider skipped the question. This could lead to various issues, to include incomplete differential diagnoses all the way to liability questions. Having contradictions or misplaced information in the review systems or physical exam. So always remember that the notes you document are considered a legal document, and contradictions could become a huge issue if they were ever to be presented in a court of law. Many instances of contradictions occur when the template is preloaded. Be sure to double check all areas of the chart so that the information gathered and document is consistent with actual events. Having quote-unquote reviewed all selected rather than none when no imaging or lab studies were performed. So again, this often occurs when the documentation template is preloaded. In other words, if no lab or imaging studies were done or they were not reviewed by the physician, do not mark reviewed all, because it didn't happen and it's false. Forgetting to refresh the lab and imaging results section. So a lot of EMRs will intermittently refresh every 10 to 15 minutes, but if you're waiting on stat labs, we should be keeping an eye on that and refreshing it ourselves. So refresh frequently. Be sure to do it right before the physician signs off the chart so you can be sure all results are captured and reviewed. The refresh option varies depending on the EHR you're working in, but most programs will be available on all pages of the chart. New labs or imaging results may even be highlighted to more readily alert you or the care team to the new information and to let you know that it has not been reviewed yet. Not utilizing Notepad. So a lot of, depending on your care area, you're going to be working in a fast-paced environment. If you're not used to documenting in the EHR, but you need to capture all the information, sometimes jotting notes in Microsoft Word or Notepad can be helpful. It comes in handy when your provider is ready to dictate to you and your EHR is loading between pages, or there's an issue and it's slow. As always, keep HIPAA in mind. The document should never be saved. As soon as the information is inputted into the EHR, be sure to delete it from the extra document. Leaving out terminology you do not understand. So this is a common happening in newer scribes. There's a lot of very complex words for medications, for diseases, for procedures. Just verify any words or terms you don't understand or know how to spell with the physician. Afterwards, make a note to yourself to become more familiar with that phrase or term. Missing phone calls. So remember, document all phone calls into the chart. When your physician is finished with a phone call, be sure to note time, length of phone call, and who they spoke with. This should be easier to do because you should be pretty much hip to hip with your physician during that shift. Forgetting to timestamp. So each EHR should have a quick click timestamp, so use that frequently. Times are important for a number of reasons that we've already learned about. Core measures, many quality initiatives. It also comes in handy when determining billing time. So you can use that during procedures, when the physician re-enters the room for reassessment, etc. Mistitling staff. So be sure to have the right title designation on notes, i.e. is the person a medical doctor? Are they a doctor of osteopathy? Are they a nurse practitioner? Are they a PA, etc.? Forgetting to charge laptop or workstation. So This is self-explanatory. This is more of like a mistake that you're making that's going to make somebody else's shift pretty terrible, especially if it's at the end of shift. Make sure you charge your workstation as appropriate and foster an environment where others do the same. Plug in your workstations when not in use, and be sure to plug them in at the end of the shift. Any questions, comments, or concerns, feel free to let me know.